Yeah, so the next patient is a 60-year-old male patient. Left eye vision is 618, improving to 612. Grading is it's an NS2 with PSC. Fundus findings are absolutely normal. Coming to the biometry, it's a plus 20.5 diopter, Vivinex impressed by Hoya. The CD ratio is on the CD count is on the lower side, 2030. Over to you, Anurag, sir.
Thank you so much, Priyam. Good morning, ladies and gentlemen. Am I audible at the venue?
Yes, sir, you're.
Yeah, Anurag, we can see everything. Thank you.
So, gratitude in abundance to Dr. PB and his team for the kind invite as we get underway. There are three things that I would like to just speak about before we move on. Can we have the registration, please? So we are using the Varian image guidance for registering the eye, just for the okay. So it has registered the eye now. The microscope we are using for today's surgery is a Luxor Revalia coming in from the Alcon Laboratories. One can see the red reflex. That's so wonderful. सीधा देखिएगा, दोनों आंख खुले रहेंगे. So this is the way I make my incisions, both the side port and the main port together. At the blue line, preferably, the side port incision holds the eye while the main port enters, and then the side port withdraws by just extending it a little bit. So I don't like anchoring the conjunctiva when I'm fashioning my incisions. So all three ports are made before even the first solution gets into the eye. You can switch off the variant now, please. Switch off the variant, please. So after the incision, the next guidance I receive from the variant is when I implant the toric. This particular IOL, as has been explained by Dr. Sonu Goyal earlier, is coming from the house of Hoya Surgicals. It's called Vivinex, and the platform is called Vivinex, and this particular IOL is called the Vivinex Impress, which is the enhanced monofocal. That will be the highlight of the surgery in the later half, but right now we are underway. We have fashioned all the sections, expanded the AC with viscoelastic, and now we are underway with the rexis. If you're wondering why I'm not using Varian for my rexis, is because Varian has actually been a fantastic teacher to me over the past few years, and it has done its job training me on how to size and locate the rexis perfectly on the visual axis and of appropriate size. So I don't use the image guidance anymore for my rexis. I do it without the help of that. So at times the overlay actually kind of disturbs me a bit because it comes to one eyepiece and not both. But it's done a wonderful job teaching me in the earlier days, I must say. So the fluid wave goes from one end below the nucleus a little bit, from the other end below the nucleus a little bit. This is a softest nucleus, as has been already told by Priyam in the initial part. It's Kerala is not very softest. Very firm believer of your school of thought, Vasavada sir, of just swirling the nucleus a few times to kill the peripheral epithelial cells to prevent, please, to kill the peripheral epithelial cells to prevent future occurrences of PCO. So it's a little tricky at times when the cataract is too soft and you not get a proper line of cleavage. But if you happen to get that, it's a wonderful thing to do so that the subsequent maneuvers of handling the nucleus is easy. Okay, is it better now? Please. The other is it centered now? Okay, so the one thing that might just catch your attention, sir, is the parameter settings on the dials on the right hand side of the screen. Please. So I am someone who looks to handle cases with much lower parameters. Sorry, going out of the field. फिर मैं चलाइए please. Is it better now? So the IOP always stays with 20 when I operate. This is a softish cataract, so I'm hardly using any power to chop. It's just a vacuum chop, as you can see. I'm not using much of power to chop this. Difficult for me to rotate it, so just take out the piece at the distal end, go to the quad mode, the IOP stays at 20, and I will just use the fluidics of the machine to aspirate it out rather than using any power. So what is impressive out here is even if I'm using very low parameters like the IOP of 20, and if the aspiration rate also is hardly at 23 or 25 in the quad mode, and the vacuum stays at 450, panel doesn't drop at the fag end. Even with that, you hardly get any fluctuations in the AC, and what's even more important is your surgical time is not prolonged. So many people think that by escalating or stepping up or bumping up the fluidics of the machine, you just save on the surgical time, which is not always true. Can still maintain the surgical time to be pretty fast, and this is an exclusively fluidics based surgery. I'm not using any power up till now. I'm sure you can see that on the CDE count. I was told that the endothelial cell count was low for this patient, so it's better that you stay off using power as much as possible and try to manage anything with the equilibrium fluidics that this machine has to offer. The vacuum rise stays at 0. I keep it at -1 for very hard cataracts at times, but most of the time it stays at 0. The irrigation factor, which is a leakage compensation mechanism, stays at 1.2 for any standard 2.2 millimeter incision. So was the case here too. So we are done with the nucleus, which is softish. We are trying to aspirate the epinuclear stacks or stretch elsewhere. All that has been done with only the vacuum, and you hardly need the use of any power.
Anurag, I'm really impressed that you didn't use the energy at all. Although even if you had used it, that's okay, but this was very good. And even with the low IOP and low aspiration flow rate, you did as fast as possible. So wonderful.
Thank you, sir. Go to the IA mode next, just to clear whatever shred of epinuclear plate that's remaining. The IOP is just scaled up a little bit to 22, but the vacuum is 600 panels. So we don't have the support of the active sentry when we're using the IA mode. The active sentry only works with the phaco mode. So even without the support of active sentry, even with the vacuum staying very high on the panel at 600 and the IOP at 22, you will see that the anterior chamber hardly flinches. So it's so stable all throughout. I really enjoy, I think everybody does that. Everybody enjoys operating this way with a modern phaco machine. Now coming to the highlight of this particular procedure, the IOL, which is, give me the hydro please. So just a few strip-on strands of cortical fibers. I don't like the polish mode on the machine. I much rather like to flush them out with BSS, which is what I call the hydro polish. And I also direct the cannula up towards the endothelium to clean the endothelium of whatever little strands of visco that are attached, along with a few cortical fibers as well. Now the bag is almost ready to receive the implant. So this is the Vivanex Impress, which is the monofocal plus. The assembly is the same as Sonu sir has so elaborately exhibited in the earlier part of the session. So this is step number 1, wherein you push in viscose to this hole that's there, and it goes to the tip. Step number 2 is remove the lock, and step number 3 is advance the latch here, which releases the assembly from its folder. Once you do that, the only thing I would like to show you is, you saw the model name to the XY1G in the geometric. It's called EM for Impress. Produces a defocus of 1.25 diopters for the intermediate. Patients are very happy. I've done around 10 of these in my practice in the last 2 or 3 weeks since the consignment came to me. And patients are very happy. They are getting around N8, not around, exactly N8 at 50. And most of them are achieving N6 with a +1 add. That was amazing. I've not done a bilateral implant till now. But I'm sure after doing a bilateral implant, I would actually leave the choice of using a pair of reading glasses whenever patient wishes to use it. I will not force it at all, because I think most of them might not need it. So I prefer the implantation of the IOL under BSS. I don't like using viscoelastics for the job, and just bloat the AC with the BSS. However, the IOP just scales up a little bit from the normal 20 or 22 to 46. But the Matanko, please. Sorry about that. The patient just squeezed a bit. And what's important with the Impress is, although it's an enhanced monofocal, I'm just moving the head here and there. You can see no change on the surface. So the surface change is not at all evident. These are microscopic changes which are brought about. The Vivinex platform is an IOL which has an anterior asphericity. So the anterior surface is plano, and the central 2 millimeters, they have brought about microscopic surface modifications to impart the add bar or defocus of 1.25. So essentially it behaves like a monofocal IOL for distance. सीधा देखिएगा please, दोनों आंख खुले रहेंगे. Thank you. So essentially it behaves like a monofocal IOL for distance and gives a very good intermediate vision at 50 centimeters, which does the job for most of the system users, computer users, tab users, people who like reading from digital screens. And then with a minimal add, they achieve excellent near vision as well. So if you're wondering why there are no surface changes evident, because it has been microscopic. They call it the free form modification of the anterior surface. It's very interesting science that has gone into it, but it does the job beautifully well. So right now the IOL is well centered in the bag. You can see the rexis overlap all around.
Yes, elegant, Anurag.
Just hold on, take a deep breath. You did a wonderful job for us, and we can't thank you enough. Great and great explanation. Thank you.
Thank you so much, sir. And thank you, ladies and gentlemen, for watching.
Yeah, a round of applause for you from the audience, Anurag.